Hello, everybody. Just double checking to make sure I have this recording. I think we're all set. Thank you for joining us in Merck Animal Health's virtual showcase presentation. I'm Chrissy Schneider. I'm one of the equine professional services veterinarians for Merck Animal Health, and we are very excited to host Dr. Nicola Pusterla in our virtual booth here today to talk to us about and teach us some things about EPM. So EPM, as you all well know, still presents a lot of challenges for us, really anyone who's working on or working with or loving horses. And Merck is committed to continuing to contribute as much as we can to the body of knowledge about EPM. Currently, that is taking shape in ongoing studies investigating ways that we can protect our higher risk population from clinical signs. I guess briefly just about the professional services team. Our phone number and our email are there at the bottom of the screen. Hopefully you can see that. And keep in mind that we're here for you. We're here to help you any way we can. So please don't hesitate to reach out either of those ways or through our website or through this virtual booth through AAEP. And we are, as I said, very excited to welcome Dr. Pusterla here with us today. Tell you a brief bio about him. He graduated from the School of Veterinary Medicine at the University of Zurich, Switzerland in 1991. He earned his PhD degree also from the University of Zurich with an emphasis on vector-borne diseases. He joined UC Davis in 1998, where he currently has an appointment as a professor in equine internal medicine and dentistry. He's a diplomat of the American College of Veterinary Internal Medicine and the American Veterinary Dental College. And Dr. Pusterla's research focuses on selected aspects of equine infectious diseases with an emphasis on epidemiology, clinical disease understanding, diagnostics, prevention, and treatment. So again, thank you, Dr. Pusterla, for sharing your time and expertise with us today.
My pleasure. Can you hear me, Dr. Schneider?
Yes.
Wonderful. Well, good morning, everybody. First of all, it's always a great pleasure to be here. And, you know, one of the exciting part is I got to dust off my tie. So that's a first, as was long due for the past 6 months anyway. So it's a great pleasure to be here. And I've been very fortunate to be supported by, you know, many good collaborators in this field. And we all recognize EPM as, you know, sometimes a field that isn't moving fast enough, or a field that is always a little bit in the gray zone. And this is really what I would like to do today. So I'm going to do a few technical challenging things here. I'm going to share my screen so that you will know what we will be talking about today. So here we go. Coming up. Very good. Again. So first of all, I wanted to thank Dr. Schneider and the Merck Animal Health team for inviting me. It's always a great opportunity to talk about a topic that I feel is not only interesting, it is interesting for me. I look at the research and the diagnostic part, but I realize that on the other side, when you're the person that has to respond to a case like that, there are definitely still some unknown area and sometimes some confusing area. And this is really what I want to talk about, is to give you a little bit of information and maybe build your level of comfort, hopefully not make you doubt your clinical skills, but build your level of comfort so that you can approach these cases with a little bit more certainty in the likelihood of EPM. And that's truly what it comes down. You know, other than taking the brain stem or the spinal cord out, you wouldn't have a definitive diagnosis. So you really have to work around it. And where I would like to put the emphasis today is in diagnostics. And I'll spend a little bit of time on the clinical aspect of the diagnostics, but also about new information that we have gathered this year, and then dive in the last part into prevention. I have a few little disclosure. As Dr. Schneider said, I work at the University of Davis, great place to be right now. I'm not going to tell you what the weather is, but it's actually pretty nice out there. That university, that place also provide diagnostic modalities for the testing, serological testing by IFAT to Sarcocystis neurona and Neospora husei. So I want to emphasize that. I'm slightly biased towards the IFAT, but in my opinion, both immunodiagnostic, quantitative immunodiagnostic that are available today, the IFAT and the SAG 243 are, in my opinion, similar in their overall performance. So you can look at these two tests interchangeably and use the test that you feel comfortable with. The studies that I will be presenting today have been partially funded by the Center for Equine Health here at the University of Davis and Merck Animal Health. We have had a long-lasting collaboration at various levels, so respiratory surveillance studies, but also in investigating some of the preventative measure using the new product Pusterla. This is what I would like to touch on today. I talked about that, so I'm going to dive in right away and just to broaden up the spectrum of pathogen that play in that sandbox called EPM. We recognize Sarcocystis neurona, and that pathogen, without any doubt, makes the bulk of all the cases. And I would say, probably 85 to 90% of the cases. But you also have to recognize, and if you haven't diagnosed them, if you haven't tested for them, there is another less prevalent apicomplex protozoal organism known as Neospora husei that in our practice area here in the Western US makes up for approximately 12 to 15% of our EPM cases. And to make it a little bit more complex, in recent study that were performed looking at additional protozoal pathogen, there's been a strong association between EPM suspect cases, which mean like cases that walk and quack like they have EPM, in which other neurological diseases have been ruled out. There's a high association with these EPM suspect cases and high titer in peripheral blood to Toxoplasma gondii. I want you to keep this thought in mind because I'm gonna circle back on Toxoplasma gondii and share some pretty cool information that looks at the potential implication, the potential role of these protozoal organism in a minority of EPM cases. So I really want to come down into clinical presentation. And as you all know, EPM is a huge mimicker, which means that, anytime a horse has some form of neurological deficit, you almost invariably always have to consider EPM. I do realize that, however, we need to have and do diligence due, which means that if a horse has orthopedic condition, is lame as example, then I probably wouldn't engage in EPM. If the horse has muscular diseases, then probably wouldn't do either, which means that anytime you get confronted with a horse that has deficit that may be compatible with EPM, you want to be sure that you just not only engage in a neurological exam, do a proper physical exam, determine if there's underlying myopathy, but also do an orthopedic exam. Now, as I mentioned before, EPM being a parasite, it has a great affinity to brain, brainstem, and spinal cords. And generally, it is where it causes the inflammatory disease process, where the neuroinvasion happens, that neurological deficit will occur, which means that the sign depends on where throughout the central nervous system the organism causes that inflammatory infectious response. Commonly in spinal cord infection, we will notice initially weakness, gait abnormalities, ataxia, proprioceptive deficit, as well as focal muscle atrophy. If brain or brainstem are affected, that generally impacts the overall attitude and mentation of the animal. We occasionally see cranial nerve abnormalities, and in rare instances, we have seen horses that actually presented for acute onset of seizure activity. As you can see, these clinical signs, spinal or cerebral brainstem signs, are very broad. But one of the characteristics that you always have to keep in mind, and that will probably help you in most instances, is to consider that this condition, sarcocystosis neospora, will invade the central nervous system, generally cause progressive signs, meaning that they increase in intensity, asymmetrical, that's just the random nature of where the organism crosses the blood-brain barrier and then invades the central nervous system. And it is also commonly multifocal, which means that multiple sites within the central nervous system are affected. So again, I want to re-emphasize that. If you have progressive, asymmetrical, multifocal clinical signs, you have to put EPM as a diagnostic, differential diagnostic, and you have to put it high on the differential list. On the other side, if you have a peracute onset, symmetrical, or even progressive and symmetrical, then I'm not saying it is not EPM, but you have to consider other neurological diseases, maybe more likely neurological disease. And that's truly is going to impact your diagnostic workup. And I want to illustrate that with 3 cases. So what I'm going to do next, I'm going to show you 3 videos. And don't worry if you don't capture all clinical signs in these horses. What I want to do then is tabulate the clinical sign, just to show you these different horses. Okay. Starting with the first horse, this is a horse that presented with acute onset of recumbency. We were able to get it up fairly quickly. You can see that this horse has mostly hind limb, is showing hind limb ataxia, weakness, and proprioceptive deficit. Symmetrical signs affecting the hind limb with an acute onset of presentation. I'm going to move to the next horse here. This is a horse that presented with an acute onset of being obtunded, having front limb and hind limb proprioceptive deficit, dysmetria, and ataxia. You can see this horse is very sluggish. It's not just a video, it's playing slowly. Careful on the turn. And you'll notice when the horse comes back, this horse is displaying cranial nerve deficit as well. The tongue is sticking out. You can see the tongue is sticking out. I'm going to get to the third horse, the one on the bottom. This horse actually had a history of 3 weeks of lip droop to the left. He also, according to the owner, wasn't ambulating right. So when we saw this horse showed, as you can see, hypermetria involving mostly one of the pelvic limb with muscle atrophy at the level of the croup. This horse also had muscle atrophy at the level of the masseter muscle and cranial nerve 5 and 7 deficit. I've tabulated here the clinical signs just to really compare these 3 horses. All these 3 horses were young to middle-aged horses. They all presented in late summer, early fall. If you look at the vaccine history, 2 of them were vaccinated. Horse 2 had no history of vaccination against West Nile virus. Mentation was obtunded in horse 2. That horse also had elevated rectal temperature. If you look at ataxia, first horse had severe signs of symmetrical ataxia involving mostly the pelvic limb. The second horse had front and hind limb symmetrical ataxia, while the last horse, horse number 3, had hind limb asymmetrical ataxia involving mainly or only the right hind limb. All horses were weak. Muscle atrophy was seen in the third horse. Recumbency was initially noticed with the first horse. Cranial nerve deficit were prevalent or present in horse 2 and horse number 3. So now you can ask yourself, well, in which one would you consider EPM? The first one with acute onset of hind limb symmetrical sign. In horse number 2 that is obtunded febrile and has front and hind limb ataxia. On a horse number 3 that has a more progressive presentation of asymmetrical signs. We run diagnostics, as you can imagine, minimal database, CBC biochemical panel, and a CSF analysis, and some differential specific diagnostics. You look at the CBC and biochemical panel, horse number 2 was lymphopenic, horse number 1 had mildly elevated muscle enzyme, you would expect with a horse that had an acute onset of recumbency. Horse number 2 was mildly hypoglycemic. The CSF was normal for horse 1 and horse 3. Horse number 2 had a lymphocytic pleocytosis, elevated nucleated cell count, predominantly lymphocyte, and elevated protein concentration. We had to rule out EHV1 in horse number 2 because the acute onset, as well as the elevated rectal temperature, that horse tested negative in blood and nasal secretion by qPCR. Because of the vaccination history, we also tested horse number 2 for IgM against West Nile virus using the West Nile virus IgM capture ELISA, and that animal tested positive in serum and CSF. But you notice we didn't test horse number 1 and horse number 3 because West Nile wasn't a differential in these horses. We did immunodiagnostic on all the 3 horses. Horse number 1 was negative meaning below the cutoff titer in serum and CSF. Horse number 2 was positive in serum at a titer of 160 and negative in the CSF. Horse number 3 was positive in serum and CSF with a serum to CSF ratio of 10. Now, what we also did is, based on the differential and the likelihood of the disease, we also took neck radiograph of horse number 1 and found a compressive lesion at the level of C5, C6. So if you look at the diagnostics that are helpful in determining the diagnosis, for horse number 1, the neck radiograph helped determine that this horse likely had cervical vertebral myelopathy. Second horse was deemed to be infected with West Nile virus, and horse number 3 had the clinical but also immunodiagnostic results that were supporting EPM. So the question is, what I'm trying to illustrate with the 3 cases is that, as example, you gotta really focus on the diagnostic that supports the top differential. If EPM isn't a top differential in case 1 and case 2, we have no business at testing for it. If you look at horse number 2 with a serum titer of 160, by definition, it is positive, but the history, the clinical presentation, and additional diagnostic really point towards West Nile. So if I, as example, as a veterinarian, feel like EPM is top on the list in that horse, despite the clinical signs that are truly not sustainable for suspect EPM case, it would be tempting, and would I say very tempting, to look at serum titer of 160 and say, well, this horse is positive in blood, meaning that this horse has likely EPM, and treat this horse for EPM. And that brings me down to, the role of immunodiagnostic. And I know that this is information that you probably have heard so many times, but it is still worthwhile considering and rehashing a little bit. So what does a antibody titer or lack of positive antibody titer mean in peripheral blood? And I would say the greatest value of immunodiagnostic serology performed in blood is in a negative result. The negative predictive value is where we truly put the emphasis in blood serology, which means that a negative result is likely associated with no EPM. So negative serum means no infection, or potentially in acute or peracute cases, these can happen with EPM. They are not most prevalent, but you can see an acute onset of EPM, meaning that the body hasn't had enough time to mount a detectable antibody response. The other option is you're dealing with another of the 2 versus or potentially 3 protozoal pathogen, meaning that if your laboratory only tests for Sarcocystis neurona and the horse is infected with Neospora husei, then you can imagine that the serological test against Sarcocystis neurona will be negative. Now, a positive result means infection, but infection and neuroinvasion is not the same. And that is mostly because Sarcocystis neurona and Neospora husei are protozoal pathogen that are widely distributed and prevalent in the Americas. And you can see from serological studies that were conducted a few years ago, so fairly recent, looking at over 5,000 healthy adult horses across the US. You can see that the seroprevalence against Sarcocystis neurona in these healthy horses range from 68% Western US to top 84% in the southern states. For Neospora husei, it's generally around 30 to 35%. So the overall, what I'm trying to show, what I'm trying to say with this graph is that the seroprevalence is really high, meaning that 3 out of 4 healthy horses in the US will test seropositive to Sarcocystis neurona, and 1 out of 3 horses will test positive for Neospora husei. The magnitude of the titer, so that value is and does not differentiate between infection without neuroinvasion and infection with neuroinvasion. So in order to really refine the diagnostic, we have to get to a biological sample that is closer to where the disease process really originates, which means that we have to use cerebrospinal fluid. I realize that it's not an easy biological sample to happen, but still, this is where you can actually support or rule out a diagnosis. We know that a negative result implies that there is there's a no chance, let's say no chance, it's very unlikely that the organism has invaded the central nervous system. Again, we can, in very early stages, be at a level where the antibody response is too low to be detected. The other option is that we're dealing here with another organism. Again, if the laboratory tests only for Sarcocystis neurona, then you can imagine if the horse is infected with Neospora husei, that immunodiagnostic will be negative. A positive result means mostly that there is a good connection with EPM. There is likelihood of neuroinvasion, but we also need to take into account what can lead to a false positive CSF result. We know that blood contamination is one of the confounder, meaning that if you're dealing with a horse that has a very high peripheral blood titer and there is a noticeable blood contamination, meaning that the CSF is in color slightly pink, you can imagine that some of these blood antibodies that have contaminated the CSF will now be detected in the CSF. The other aspect that has become more obvious in recent years is that antibodies, the magnitude of antibody, they have a tendency to diffuse along a gradient, which means that the more antibodies are present in peripheral blood, the more likely you will find by pure diffusion antibodies into the cerebrospinal fluid, which means that today, in order to truly support via laboratory immunodiagnostic an EPM suspected diagnosis, we have to have evidence of intrathecally derived antibodies. And the best way, the more academic way to do that is by calculating indices, which means that we determine the antibody titers in peripheral blood and CSF, and then put that in a ratio with protein that are distributed between blood and CSF. Albumin can be used, or total immunoglobulin would be the other option. because that is very difficult to do, and not all laboratories offer these diagnostic modality. It is very important, or at least today, based on the EPM consensus statement, that we use a proxy. And the proxy is to calculate a serum to CSF antibody ratio. We know that approximately one antibody will cross the blood-brain barrier for every 130 to 250 antibodies present in peripheral blood, which means that a serum to CSF antibody ratio in a very conservative fashion that is below the 130 will equal or will support intrathecally derived antibodies. So just to set the field straight on immunodiagnostic and how to best use them. And I'm very excited to be able to actually move into information that is yet not published, in the process of being published. So you're the first people that really get to hear about this. It's looking at, as I mentioned earlier, the role of Toxoplasma gondii. In a study that was done a few years ago, Dr. Caitlin James showed that horses with EPM clinical signs, or clinical signs compatible with EPM, were almost 4 times more likely to have high to very high titers to Toxoplasma gondii compared to control non-neurologically affected horses from the same geographic area, hinting that there may be an association between Toxoplasma gondii and EPM suspected cases. We're fortunate, because we have an immunological lab, to have a lot of banked material. We went back and used 210 banked serum and CSF paired sample from EPM suspect horses. These are horses with clinical signs compatible with EPM. Every submission comes with a lot of demographic as well as clinical information. We then looked at antibodies to Sarcocystis neurona, Neospora husei, and Toxoplasma gondii. The idea was to determine how many of these horses were likely, based on immunodiagnostic, to be infected with Sarcocystis neurona / Neospora husei, how many of them were likely to be infected with Toxoplasma gondii, and how many of these horses potentially would be infected with multiple protozoal organisms. We used a serum to CSF ratio less or equal than 64. This threshold, or this ratio, has been established for Sarcocystis neurona and Neospora husei, has yet to be established for Toxoplasma gondii. However, in comparison with what we know about passive diffusion of antibody, this is a fairly conservative ratio. The data, as you can see here, 70% of the horses had no evidence of neuroinvasion based on absence of antibody in the CSF, or a serum to CSF ratio greater than 64. Close to 20% of the horses had immunodiagnostic compatible with neuroinvasion with Sarcocystis neurona / Neospora husei with a serum to CSF ratio less or equal 64. 15 horses, or 15 CSF sample, representing 7% of the 210 sample, had a serum to CSF ratio of 64 or lower than 64 for Toxoplasma gondii, suggesting neuroinvasion with this organism. And then close to 3% of these horses, or the CSF sample, had a mixed infection, meaning Toxoplasma gondii with one of the 2 better established apicomplex or protozoal organisms. So truly not knowing which organism was driving the disease process. When we looked at prevalence factor from the submission, looking at time of the year, origin, signalment, clinical signs, the only association that we found for Toxoplasma gondii suspect horses was breed. These were warm blood. So greater frequency of warm blood in the submission with EPM signs that tested positive for Toxoplasma gondii in blood and CSF, meaning that at this stage, we should at least consider and entertain the possibility that Toxoplasma gondii may be the third protozoal organism that may be associated with EPM. There's still work to be done. I mean, at this stage, we haven't detected Toxoplasma gondii within the CSF or the central nervous system of horses with EPM. We've gotten too good at treating these horses, and Toxoplasma gondii would actually respond to the treatment options that we have these days with triazine, as well as the combination of sulfa and pyrimetamine. I want to move to an additional diagnostic or new diagnostic information, and I'm going to illustrate this with this case. This was a 10-year-old quarter horse mare that we saw a few years ago with an acute onset of one pelvic limb. This horse showed right hind limb weakness, dysmetria, and proprioceptive deficit. So we have acute onset and we have asymmetry. So if you look at the clinical or the differential, where do you put EPM? It's not progressive, but it's asymmetrical and it's not multifocal. But we still retained EPM as a differential. Perform a lumbosacral tap. The cytology total solids were normal. Serum and CSF IFAT for S neurona. You can see the result, positive in peripheral blood, negative in the CSF. We also tested for Neospora husia, was negative in both serum and CSF. We explored through molecular diagnostic tool, through quantitative PCR, a panel of various organisms because of the atypical presentation, mainly the acuteness of the presentation. We tested the CSF for Sarcocystis neurona, Neospora husia, Toxoplasma gondii. We looked for Borrelia burgdorferi, Leptospira, as well as EHV1. And surprisingly, that horse tested positive for Sarcocystis neurona in the CSF using quantitative PCR. And this horse was deemed EPM, an EPM case, and was treated successfully with antiprotozoal drugs. And that brought us to investigate the possibility to not only detect antibodies in the CSF of clinically affected horses, but also looking at the organism in the CSF. And this is a modality that was done many years ago, 20 years ago, in a handful of cases, and showed that approximately 40% of the horses in a very small cohort tested positive using conventional PCR. Because of the fairly slow number, this modality was actually not pursued. So what we decided to do is to go back on our repository bank sample using the 210 bank serum and CSF sample. We tested by qPCR the CSF sample for Sarcocystis neurona and Neospora husia as well, and also then compared the result using the Immunodiagnostics. And then we divided the results in 4 different categories. As you can see from this table, we have on the left the CSF positive S neurona, on the right the CSF negative. On the line, the second column is the IFAT result. Do we have evidence of neuroinvasion based on antibodies? And remember, a ratio, serum to CSF ratio less or equals 64, generally is supportive of intrathecally derived antibodies. So I'm going to start with the column on the right. 42 of these samples were negative by PCR and had no evidence of intrathecally derived antibodies. If I look at the 2 columns on the right, I'm trying to get my little arrow here. We had a total of 38 CSF samples that tested PCR positive. 13 of them also had evidence of intrathecally derived antibodies. 25 of them did not have evidence of intrathecally derived antibodies. And then we had 30 samples that tested negative via PCR. and had evidence of intrathecally derived antibodies. When we look at prevalence factors, which is again demographic, origin, time of the year, treatment, or previous treatment, as well as clinical signs, the only prevalence factor that was associated with qPCR positive CSF was the lack of historical treatment with antiprotozoal drugs, meaning that horses that had a historical treatment with antiprotozoal drug were more likely to test qPCR negative for Sarcocystis neurona. Now, the interesting part is this second column I'm going to highlight in here. Are these 25 CSF sample that was positive in CSF by qPCR and negative, or had a serum to CSF ratio above 64, which means that these horses using our conventional immunodiagnostic would have ruled out EPM. So interestingly that, these cases still provide evidence that there is genetic material in the CSF and that is likely associated with neuroinvasion. So I'm not trying to say that qPCR should replace immunodiagnostic. Absolutely not. I still believe that immunodiagnostic should be at the front of our diagnostic modalities to determine neuroinvasion. However, in instances where the immunodiagnostic, the results are not matching your clinical impression, meaning that the horse has all clinical signs compatible with EPM, you rule out other diagnostic modalities, and the result come back negative in CSF or serum to CSF ratio is above 64. And maybe this horse hasn't been pre-treated with antimicrobial. It is worthwhile considering if the CSF was collected and available already to test the CSF for the presence of Sarcocystis neurona. So I'm looking at qPCR detection as the second or the third tier of a diagnostic workup and as an adjunct diagnostic modality. Definitely not there to replace immunodiagnostics. So now move on into prevention. And you're probably all familiar with preventative measures. There's many studies that have looked at risk factors. I listed them here. And we're trying to do these days is, educate our client to, minimize interaction of their horses with wildlife, to have clean, fresh water, to have, grain and hay that is stored in places where wildlife have no access, and also to feed these horses in places where wildlife, mostly opossum, cannot come in and contaminate the environment, water, or feed with scat that then potentially could contain the spore cyst. We know that there's no vaccine available, but there is, or has been for many years, and now many prophylactic, preventative, metaphylactic treatment that have been used, where high-risk horses are treated and pulsated with antiprotozoal drugs. And I wanted to expand here on actually 3 studies that have shown the benefit of using diclazuril or protazil in reducing seroprevalence as well as magnitude of titer in horses under high exposure to Sarcocystis neurona. The first study that we collaborated with Merck Animal Health, performed a few years ago, looked at the overall seroprevalence to Sarcocystis neurona in 33 foals from a geographic area with high exposure rate to Sarcocystis neurona. 33 foals were divided into a diclazuril treated group and an untreated group. These foals were treated from the time they were 4 weeks of age to 12 months of age. You can see from this graph we have in the red bars the seroprevalence in untreated foals, in blue the seroprevalence in diclazuril treated foals. In the first 4 months of their life, I'm gonna highlight this with my little arrow, you can see a steady decline in antibody titers up to weaning time, and that represents the cholesterol derived antibodies, the decay of this cholesterol derived antibody. If you look from the weaning time to the end of the study in untreated animals, you can see that the seroprevalence, the red bar from November to April, ranged from 53 to 88%, while in the treated animal, the blue bars, the seroprevalence steadily declined from 29% to 6%. So the study results show truly that diclazuril given, and for this study, I forgot to mention that, we didn't use the FDA approved dose for the treatment of EPM. We used a lower dose with the goal to reach serum titers that are above the MIC for Sarcocystis neurona. So the study showed that at that concentration and that dosing regimen, the study showed a positive effect on prevalence in treated animal, but also magnitude of the titer. This study actually merged into a second study, realizing how far above the target we were for the concentration of diclazuril with the help of Dr. Mark Papage from NC State. We're able to model a different administration schedule and came up with the idea to actually treat horses every 3 to 4 days in order to reach plasma level that will be above that MIC for Sarcocystis neurona, but also for Neospora caninum. We're looking at 100 nanogram per milliliter. The graph here shows, the graph below shows 7 administrations, 7 individual doses at time point 0, 4, 7, 11, and 14 days. You can see the peak and the trough that was measured. So the peak at 10-hour post-administration, and then the trough for each of these doses that was given just prior to the next day. So these horses were dosed every 3 to 4 days. And what you can see is that after a single dose, diclazuril is so well absorbed, we reach high levels of diclazuril in blood. Cmax was close to 300 nanogram per milliliter. So if we truly extrapolate this to a preventative measure, this protocol actually improves compliance. It's a twice weekly, but also reduces the overall amount of drug. With 1 pill of diclazuril, of Protazel, with this regimen, you can actually treat an adult 1,100-pound horse for 6 months. But again, this protocol hasn't translated in a study that would actually look at the benefit of this protocol on seroprevalence as well as antibody titers, similar to what we did with the fall. Until last year, we were fortunate to be able to perform a study on 22-year-old horses. These horses were moved from a farm with a very low infection rate to Sarcocystis neurona, and that was determined by screening resident horses. These horses were moved to an area in Kansas, state of Kansas, with high exposure rate to Sarcocystis neurona. The idea was to randomly divide these horses into 2 groups, a treated and a non-treated group. The treated group received diclazuril at half dose, 0.5 mg per kilogram, every 3 to 4 days for 12 months. That's the bi-weekly low-dose diclazuril treatment. And these horses were followed daily by Dr. Burnett and Sandy, his study partners. And the study was performed actually at his place, and he gets all the credit for taming these animals, taking all the risk with these animals, treating these animals, and truly loving on these animals. He assessed daily the clinical status, bled these animals monthly for serology, and also bled them every other month to actually measure diclazuril level. And the study was actually in agreement with an animal use and care protocol that we established ahead. So if you look at the result, all the animals remained healthy through the 12-month period. Interestingly, these animals, the initial seroprevalence for both groups and the titers, you can see from this graph down here, represent the magnitude of the titer over time. We have in green the treated animal, and in blue the control animal, showing the mean titer, maximum and minimum titer. So at the beginning of the study, we had equal seroprevalence around 40% and similar distribution of titer. The seroprevalence reached quickly 100% in the control animal by day 60 of treatment. It took 90 days for all the treated animal to reach 100% seroprevalence. And with seroprevalence, we deemed a titer greater or equal 40 using the IFAT against Onchocystis neurona. Now, where the significant difference was in the magnitude of the titer. You can see this with this graph. If you compare the different time point 30, so these are 30 days since start of the treatment, to 360, the treated animal, showing here in green, had a significantly lower titer distribution than the untreated animals. If we look at diclazuril, that was the other part of the study. The study showed that at each of the 6 time points, every 60 days, these animals displayed serum concentration of diclazuril that were way in excess to the MI seen for Onchocystis neurona. That minimal inhibitory concentration has been established in vitro. There was a significant difference between day 60 and the other days. A lot of that had to do with the management of these fairly wild and unbroke animals. And I believe that Dr. Burnett is on this Zoom presentation. So maybe he can comment a little bit on some of the challenges that he definitely must have had throughout these 12 months. So the study really shows that the biweekly diclazuril administration in these young horses was able to significantly reduce the titer, the magnitude of the titers. Now, none of these horses developed EPM, none of the control nor the treated animal. However, we need to take into account that the overall attack rate is relatively low. It's going to be very difficult to establish a study that look at the endpoint. We use serology, seroprevalence, and magnitude of titer as a proxy to determine inhibition or establishment of infection in treated versus animal. Every presentation comes to the end, so look forward. Lunch is just around the corner here. I just wanted to finish with a few take-home message. And I realize EPM is a complex topic, but as much as I want to take shortcuts, I can't. I can't look at a horse not doing diligence due, not doing a true neurological exam, not doing an orthopedic exam, and just pull a blood sample and then deal with the titer, and the titer will then influence my treatment. I can't do that. So there's no way, if you engage in EPM, that you can bypass what we consider the gold standard of diagnosis, which is, neurological exam, proper immunodiagnostic, ideally performed in blood as well as CSF. One of the mistakes, and I wouldn't say a mistake, one of the temptation that I see a lot is veterinarians that jump into immunodiagnostic as soon as the horse takes a wrong step. Meaning that, horses with gait abnormality, lameness, orthopedic issue, myopathy, or horses that have neurological signs that are not necessarily consistent with EPM. That horse with, acute onset or recumbency, acute onset of symmetrical disease, or even progressive symmetrical disease. While EPM may be on a differential, EPM is not going to be the top in the differentials. Try to avoid to pull blood samples. Now, if you run blood and CSF is absolutely different. The other approach is, while only EPM suspect cases should be treated. I believe that there's a spectrum where too many horses are deemed suspect for EPM and are treated, but they may have an other underlying condition, which means that they will not respond to the treatment. And it's then tempting to say, well, the treatment doesn't work. Well, maybe the horse didn't have EPM. Maybe EPM wasn't at the top of the list. So you truly had no business at treating this horse. So the treat and see approach, I would be careful. Now, I'm going to disclose something, and if it ever comes back and bites me, I'll deny that I was on this conference call. I hope that Chris is not taping this. So there'll be instances where, from a practical standpoint, you cannot perform a CSF tab. Either it's too dangerous, you're not comfortable doing it, or the owner doesn't have the financial means to support CSF collection, cytology, and all the immunodiagnostics. If you have an instance where that horse walks and quacks like it has EPM, so you really have done your basic workup, clinical, physical, neurological, lameness examination, you feel like, you know, EPM is really on top of that differential list. And you feel like, you know, the immunodiagnostic are just going to confirm what I really suspect. You can run serum for the value of a negative result, meaning if it's negative and it's a progressive chronic condition, then you invariably have rule out infection, as long as you test for the various protozoal organisms. In an instance like that, I would feel strongly that it is justified to treat the animal. But the question is, how do you treat, how long you treat, and what you do during the treatment? My philosophy to that is that you can treat a horse that is an EPM suspect without doing a CSF. Treat the horse for an adequate amount of time in which you would expect improvement if the horse truly has EPM and responds to the antiprotozoal drug. So let's give it 2 weeks. What do you do after 2 weeks? After 2 weeks, you come back. You, not anybody else. You who has established that initial suspected diagnosis, reevaluate the horse and objectively determine, is the horse equal, worse, or better? Because if it's equal and worse, you have to look for something else. And you only invested 2 weeks of treatment. If the horse is better, then you could argue that you may want to finish the treatment. As long as there is space for improvement, it is worthwhile considering treating this horse. And how much improvement do you like to see? Enough that it is noticeable. Video the animal to be sure that, you know, you remember 2 weeks ago how severely affected the animal was. I like to see a minimum of, you know, perceived improvement, 25% improvement of clinical signs before, you know, I get the little confidence boost that, you know, EPM is still top there. I'm going to finish the treatment. But again, these, in my opinion, should be exception, but they are still justified. I just want to expand a little bit on the immunodiagnostic. If your animal walks and quacks like it has EPM, is negative for sarcocystosis neurona, and you haven't tested for the other protozoal organism, you may want to consider testing for Neospora husei as well as Toxoplasma gondii. And last but not least, in times where horses are stressed and move around, and we cannot afford to have a horse develop neurological disease due to EPM, because that generally surely stalls the performance career of that animal, there are preventative safe protocols that have been shown to, as a proxy, reduce seroprevalence and titer magnitude. So they seem to be beneficial in keeping and preventing EPM. With this, at the end of my presentation, I'll be glad to answer any question. If you have any question, if, you know, some of the question come back later in your mind, I put a phone number. It's not my cell phone number, it's the lab's number, but you can always leave a phone message. You can email me anytime if you have any question. It can be on any help in interpreting some clinical presentation, immunodiagnostic, or help you in any way with these cases. Feel free to contact me.
Thank you so much, Dr. Pusterla. We'll maybe wait just a few more moments to see if anyone has a question. You can raise your hand and I can unmute you, or you can type it in the chat. I don't have anything so far. So I think if anyone has any questions, reaching out to Dr. Pusterla or anyone on the Merck team, if it's something we can help with, we're happy to. So thank you so much, Dr. Pusterla. We really appreciate your time. That was a lot of really great information. And thank you so much.
My pleasure.